BVGA to do the introductions for our presenters, our speakers tonight. We've had very enlightening presentations over the past 9 weeks, and I'm very expectant that we would also have same today beyond. I think Kati is on. I can see that you're on.
Yeah.
Okay, very good. You're unmuted. So maybe you should.
Certainly happy to kick things off. So it's my pleasure to introduce you to Dr. Oluwafemi Popoola, who will be giving today's lecture on clinical trial implementation logistics. Dr. Popoola is a lecturer in the Department of Community Medicine, College of Medicine at the University of Ibadan, and a consultant community physician to its allied teaching hospital, the University College Hospital, Ibadan. His research interests include community control of non-communicable diseases, patient safety, tobacco control, and clinical epidemiology. He is involved in research and teaching at various levels and coordinates training at the university's Ibarapa program. So thank you very much, Dr. Popoola, for giving today's lecture.
Thank you so much. Good day, and I hope everybody can hear me clearly. Thank you, Kathy, for the warm introduction, and it's a pleasure to be here. I think that I know there's a lot of capacity in the room. I was in here for a few minutes, and I know they're very senior people who are very skilled with this, and it's a pleasure to have this conversation with you all. Now, what I want to focus on, what the text of most of what I was talking about is the ideas around quality assurance, and I'll say a bit about standard operating procedures. And I hope that in the conversations afterward, we may speak specifically about how this will translate into implementation of clinical trials. I don't have all of the material for the 12-week training program, but I imagine that there's a lot of procedural stuff that has been said about clinical trials. So I'm going to try to focus on what was the core of the lecture that was the basis for the introduction, which is actually about clinical assurance as an idea, continuous quality improvement. So just to run through what the objectives of the session are, I want to define some terms related to clinical assurance and outline processes in QA, talk about a few tools, and then just mention the role of standard operating procedures. And I hope that when we get to the discussion, we'll be able to share different experiences about how SOPs have worked and what some of the strengths, limitations, and challenges of using them might be. I hope we'll have time to have some interaction in here, and I hope to learn from the group as well. So just to get it off, this is a word cloud, and we see different things related to quality in there. We come across different concepts, Pareto, Sigma, effectiveness, and all that. But at the core of it, the quality of a service is just the totality of the features and characteristics of that service that beyond its ability to meet its objectives or to meet the patient's needs, which is the core objective. And the father of quality assurance or quality-related health research is considered to be Avedis Donobadian, and this is one of his definitions, that the quality of technical care consists of application of medical science and technology in a way that maximizes health. And the degree of quality is therefore the extent to which care that is provided is expected to achieve the most favorable balance of risk and benefits. And there's nowhere where this is more relevant than in talking about clinical trials, because a clinical trial is necessary to establish the benefit of a clinical treatment, but there's that potential for harm. And the clinical trial is all about maximizing the possibility of benefit while minimizing the possibility of harm, which is one of the core principles that underlies research ethics. So at the end of it, quality is all about doing the right thing the right way. I came across this graphic and I liked it. It's from a very old paper by Brown et al. About the quality of assurance in healthcare in developing countries. But I just like it because it highlights what I think are different dimensions of quality or different components of quality. And if we look across the dimensions that have been described here, the 8 dimensions that we've prescribed. There may be other people have described more dimensions. This is by no means exhaustive. But what instinctively jumps out at us most times when we talk about quality is we think about technical competence. Very often, as good clinicians, we think about interpersonal relationships as well. But when we look across this entire spectrum, the dimensions of quality relate to all of this, including access to service. Very often, we can talk a lot about effectiveness, but efficiency is also important, and we can't get away from the safety-related issues, which is one of the bases for a lot of the prescriptive work which is done in quality assurance and continuous quality improvement circles. So these are 8 dimensions of quality which we want to think about, and we may have a conversation about the depth to which we apply some of this. So quality assurance in the end actually refers to a process of maintaining a high quality of healthcare or research by constantly identifying, assessing, and monitoring the important aspects of our care or research. In this case, our clinical trials. So we need to identify what the important elements are. We need to assess them, and we need to have benchmarks by which we monitor these aspects of care. And that process needs to be iterative and repetitive, and it must be a process that learns. Ultimately, quality assurance aims to prevent quality failures, and that is a bit different from quality control, which aims to detect and correct quality failures. But they work hand in hand together, and I think that trying to split both arms is probably an exercise in futility. The final term I want to define here is total quality management, which is just the comprehensive management approach to create continuous quality improvement. So these are the 3 terms that I thought were the core of what I wanted to touch on. Quality assurance, illustrate the difference between quality assurance and quality control, and to define total quality management as a concept and how it relates to the core clinical expression, which we most often see, which is the continuous quality improvement cycle, Okay, so now in the next part of the presentation, I'd like to say a bit about the QA process, something about the steps and the processes that go into QA. So quality assurance is very often a tiered responsibility. It operates at the different levels where we have strategic level, the tactical or the functional level, and the operational level. And most of us in our work, I imagine, we cut across these different levels. I imagine there are people here who are clinical trial leads, and organizational leads who deal with things at the quality or the policy level. And we have people who are more like at the clinical trial admin lead stage, which is more like the tactical or the functional level of things. And then we may have for a specific task at the operational level where you actually then have the core standard operating procedures, how we're going to take a blood sample, how we're going to store a sample, how we administer a medication, how we record that a medication has been administered, how we record an adverse event occurring, how we respond to an anticipated or an expected drug adverse reaction, all of these things. So without being pedantic about it, I think it's important to recognize the different levels that we have and the fact that there's a sense in which there can be an unconscious struggle across the levels. Very often in my experience, people at organizational or strategic level may not be aware of all the nuance that operates at the operational level. So very often you have people at strategic level, making decisions and asking for certain standards. And then people at the operational level may be saying things like, we really can't effect that. We don't have the manpower to do it. We don't have the time. The logistics are not present, So this is something that we need to be aware when we design QA processes, when we're running our clinical trials, to be aware of, especially as a clinical trial lead or as a strategic lead. It's very important that we have a consciousness of our strategic focus and goal. We can be aware of our tactical or functional level, but it's a very good idea to always interface as much as possible, even at that operational level. Come in and actually walk through and see how these procedures work, how the clinical trial space, the words function, even simple things like electricity, water supply, You can have a scenario when you're dealing at hospital level. People just say, oh, yes, we have all of that. We provisioned it. But when you come down to the operational level and you see how things work on a day-to-day basis, it can be very eye-opening about what we're asking our staff and our colleagues at the operational level to produce. And so we've had some very enlightening meetings where when I was head of the TQM in UCH, at the time, the director of clinical services and research and training, the CMAC, started doing this twice monthly hospital walkthroughs, and they were very interesting walkthroughs. You know, you go to a department, and I remember the visit to the radiotherapy department. We talked about the machines and everything being available, and when we walked through, the reality that we saw was a bit at variance with that, and it was quite an interesting conversation. So I always like to tell strategic level leads and tactical level leads that it's important to pay attention to the operational level and see how things actually operate. I brought up two QA models here. I'm sure a lot of us have probably seen these models before. The first one is the Donabedian model for quality assurance or quality improvement. That identifies three core elements to any quality assurance process. It identifies the structure, it identifies the processes, and then it identifies the outcomes. So it thinks about structure in terms of the inputs that you have, workplace, manpower, processes, how they come together, how those elements relate and interact, and then the outcome that they produce. A more modern one is probably the PDCA model, which is the plan, do, check, and then act again. And if you can imagine how you go from planning to doing to checking to acting and then going back to planning. And this is a cycle of how we generate continuous quality improvement within our clinical processes. This is a big description of the quality assurance cycle. I'm not going to speak to it. I just wanted to put it up. It's a bit more detail on the plan, do, check, act model. So it goes from planning to setting standards, communicating standards, monitoring those standards, identifying and prioritizing opportunities for improvements. And on the basis of that is where we now get into the core of the continuous quality improvement activity, which is the place where you come in and you define the problem, you identify who will work on that problem, you analyze and study the problem, you choose and design a solution and then implement it. And then we come back again to the beginning of the cycle. Now, after implementing a named solution, we may go back directly to monitoring that solution. And 1 minute, please, let me get the laser. So we may come back from implementing down to monitoring and re-identifying, so there's a CQI cycle that works in the loop from 10 going down to 4, and then there's a broader one which involves setting standards, communicating standards, and monitoring standards, which are the things that we usually do from strategic down to tactical level of the QA process. Now, so if we're going to do a quality assurance process, what do we need to get it done? It's very often easier said than done. Everybody usually comes and says, oh, yes, we want good quality. We want good clinical practice standards. We want to do top-notch clinical trials. But what are the requirements that we need to have in place? First of all, you need to have a group of people steering it, managing it. And that group of people must include all the relevant and key stakeholders. The challenge is having the right people without getting it so large that it becomes unwieldy, in my experience. And when you approach anybody to be a stakeholder, everybody sees the stake that they have in it. So it's always a bit of a challenge getting that. But to get it to work, you need widespread publication and widespread buy-in. Everybody needs to be on board. And that is easier said than done. You need to have a culture for quality assurance and a capacity for quality assurance. So there is technical skill that needs to be involved in it. So it's actually also about training people and having people who are skilled in elements of critical analysis, problem identification, solution design, implementation, So there are critical and core skills that are required, people that can do incident analysis, retrospective reviews. And most importantly, this is the part where we tend to have a lot of the challenges, is in how we institute our frameworks for instituting corrective actions. The easiest thing to do with a quality assurance or process is to digress into scapegoating. Very often, especially at strategic level, strategic managers want to hear one thing: who was at fault? Who do we hold responsible and what do we do to them? But quality assurance and continuous quality improvement requires that we must have an approach towards problem identification and solving that is a framework approach. We start with the starting assumption that people don't willfully commit acts of harm or negligence, so that we must understand and have a framework by which we can institute corrective actions and understand what are the precursors to the final actions that are seen. So, okay, we have a clinical trial, someone gets the wrong dose of medication. But instead of just focusing on this administration of the wrong dose of medication, what were the things that predated that? Can we look at how we labeled and stored the medication? What number of hours was this person working? Are they dealing with conflicting responsibilities? So there are lots of things that go into it, and having a framework that can understand the problem holistically and design a solution rather than doing the easy thing, which is identify individual A was at fault, and then hit them with a sledgehammer. So that framework for implementing corrective action is one of the most important things that we need to have in place. Now, broadly speaking, in terms of approaches to quality assurance, we have things in the general approach that we all know. Making sure people have the right credentials and licensure, ensuring accreditation, training and retraining, and having certification. But more than that, when we come to the specific approach, we can go from a sequence that goes from peer reviews to setting standards, using audits as a tool for quality assurance, and then going up to utilization reviews, evaluation reviews, client satisfaction reviews, incident reviews, quality control reviews, and quality awards as specific tools that we can institute in a specific way to improve our quality assurance in both our broad-based clinical activity and even in our clinical trials work. So finally, I just wanted to highlight some of the factors that affect or impact quality assurance, and we can think of which do we think is the biggest or the most important challenge in our own context. We don't have a lot of time, but I'm curious about what people will think. So if we identify all of these factors, would anybody care to identify what they think is the biggest? Or what are the key challenges that we think impact our ability to produce quality in our healthcare delivery? Would anybody like to take a shot at any of them? I'd like to hear, if it were possible, I think it would be great to hear another voice apart from mine.
Okay, so
You can, I don't think many people can unmute. So maybe we just go, yes, because
Okay.
of the short time.
Okay,
It
we have
doesn't
very little time.
for good interaction, yes.
Okay, thank you so much, man. Okay, so I think that we would agree that all of this are probably issues at some point and the other. But I want to highlight two things. And the two things I want to highlight as challenges to quality improvement, the quality assurance, are incident reports and medical records. Every time I've been involved with a process that's involved these are two of the things that we've had the biggest challenges with. Records are not complete. There's a question about what happened in what sequence, or someone came after and put their needle on this, they put their finger on the scale and may have tipped it one way or the other. So these are things that we keep running into most of the time when we have to deal with quality assurance. And I don't believe that we can effectively address any of these issues without improving the quality of incident reporting that we have and having high quality medical records, including electronic medical records. Okay, so finally, I just want to talk about two tools that we often use in quality assurance processes. I've used this in some of the quality assurance work that I have done in the past, and I hope it has some utility. I'm just going to touch on them. The first one I want to point out is this problem prioritization and description matrix. As you see, I put the reference where we used it. There's this NS 360 quality assurance work that's supported by the Federal Ministry of Health. So what it does is it's a matrix where you list the problems that you have, then try to score them in terms of the impact of the problem, the cost of fixing the problem, and then how often the problem occurs. And then the problem that gets the highest score is the one you prioritize. A second step we often do with that is then we sometimes use this tool, which is the fishbone matrix, where we write the problem. So the problem we pre-identify, we write that problem in here. And then we try to identify the different elements that contribute to the problem in terms of method, people, environment, equipment, or materials. And we leave a spike on for other things. So we try to identify all the elements that contributes, and then we describe the problem in full. And on the basis of that, we try to imagine what the potential solution for these problems might be. Okay, so finally, I'm just going to say one word about SOPs. I know we're all experts on SOPs and we use them a lot with our clinical trials processes. SOPs are fixed frameworks for all project activities, and they're invaluable in the design and conduct of clinical trials. Most processes in a clinical trial will have some kind, every repeated and frequently done process in a clinical trial should have an SOP, standard for how that will be delivered, including who's supposed to do it, who monitors it, what indicators for the monitoring of that process, and how frequently they will be collected and potentially also assessed. So the frameworks need to be detailed without being cumbersome. They always have a huge expertise requirement. You always need to have people who are experts in the field and are already also working based on pre-existing clinical and practice standards to define what the standard in this research activity will be while adhering to the clinical protocols. I hope in the end we have some conversation about what our experiences have been working with SOPs. I know consultants and researchers, we are probably more naturally attuned to it, and people can probably also talk about when they used to do clinical trials when they probably first started, and everything wasn't as rigidly defined the way we do it now, and there are benefits and there are negative impacts of both approaches, but we must all agree that there are huge direct benefits to using and crafting ideal standards of practice, in clinical trials. So just to summarize overall, I've said a lot about the quality of health services, and I've said that to deliver quality health services, even within the context of a clinical trial, requires technical competence, and it needs to have a patient focus. Quality assurance is an essential tool for continuous quality improvement or total quality management, and it requires strong institutional support and high quality data analytics and support. So thank you very much for your attention. I was originally told there'll be 15 minutes for this, but I could go up to 30 minutes. I've tried to spend about 24, 25, and I hope that in the last 5, we can perhaps have a conversation, and if you people can also weigh in and educate us about the experience with using SOPs and clinical assurance processes in the context of their clinical trials. Thank you very much for your attention. And I hope I didn't bore you, go too quickly, go too slowly, and this wasn't too irrelevant. Thank you so much for your attention.
Yes, thank you very much, Dr. Popola. Thank you for taking the time and enlightening us, and thank you for sharing some of your experiences, because those always have to put things in context. For the sake of time, and because we're going to be having 2 other presenters, the questions can be put onto the chat box, or at the end of all the presentations, we will have some time to interact. But please, for now, you can put questions in the chat room, and we'll be glad to have a look at them. Dr. Popola, maybe you could also have a look at them while other presentations are going on. But thank you
Yes,
very
sir.
much for that, and hopefully we'll have another 15 minutes at the end to
Okay.
take all questions as much as
Thank you,
possible.
sir.
So moving on, I will ask Kathy again to introduce the next presenter. Please, admin, you will notice there are two categories. Please unmute both while cartograph of BBGH will do the introductions. Thank you.
Thank you very much. So it's also my pleasure to introduce you to Mr. Babatunde Osinkolu, who will be speaking about budgeting today. Mr. Osinkolu is a research administrator at the College Research and Innovation Management Unit at the College of Medicine within the University of Ibadan. He has a keen interest in research management and capacity building within and outside his institution. In his role, Mr. Osinkolu facilitates research training and grant budget development and contract processes and institutional due diligence processes for research project staff, research administrators, and researchers within and outside of Ibadan. So thank you very much, Mr. Osinkolu, for giving today's lecture.
Thank you. Admin, please unmute the other login as category. Very.
Okay, so thank you very much, Kathy, and everyone for this opportunity. Sami is my name, as I've been introduced. So shortly, I will be speaking on grant budgeting and invoicing, reporting, and payments in clinical trial. Okay, so the outline for this, that's though we have the different phases in budgeting, and of course, generally in grants and in projects. So I'll be looking at the pre-award, the post-award, and the closeout in terms of the budget. So basically, we want to look at what budget is, and most of the time when I have this opportunity to have this discussion, I always say everybody does budgets. There's nobody that doesn't go through budgets even on daily basis. So, and I know there's so many erudite scholars here that can even define more than what I can define. So I'll quickly just skip most of them. So I just put some definitions here. Budget is a quantitative expression of a plan, for a defined period of time. I always put this defined period of time because for every budget, for a clinical trial or anything we want to do, there should be a period, there should be a time, there should be a start time and end time that defines what we're going to use it for at that period. Then a valid cost implication of a project. Most of the time I tell people that when you develop a budget and somebody who doesn't know anything about that project that you want to do or the clinical trial, if it picks up your budget, you should have an idea of what the project is about to achieve. So that is going to be a good budget. That is, you have all the items, being spelled out, then what you attach the cost to. Then the financial explanation of a project, that is, your budget should be able to explain, your project, and of course the clinical trial. So the cost incurred, and so I'll just keep all this because of our time. So I need to make this clear that budget is not a lump sum but it is analyzed item by item. There was a particular budget I did, and somebody was asking me, why are we budgeting for each pencil, each pen, and all that? And I said, that is the way it should be, so that you don't leave things out. But when you leave it out, then there could be a problem at the end of the day. So therefore, a budget is your financial plan. So for the clinical trial, is a financial plan. So the budget should be well done. And there are different ways in which we can develop our budget. It could be budget of estimate, which most of the time looks at the detailed work, and provide estimates for each piece of the work. That is everything that you're supposed to do, the activities that goes into the project itself. So it takes care of that. That is, you start right from the beginning and you take it up, from bottom, you take it up and add everything up. So we have analogous. This one is based on your previous experience, and at the same time we have parametrics, which is more accurate because you are looking at using a formula based on your historic information that you have. Then, for example, if you have done a budget, you are saying it in the history, or this has been done, or maybe you've done a clinical trial earlier, maybe like 2 years ago in a particular location or in a particular site. And in this year, you want to have another one that you need to develop budget for, or possibly you're having it in another 5 additional sites. So in that situation, you need to calculate and make sure you put into consideration the inflation rate and all that. So this one is actually more accurate oftentimes. And we have apportioning. Also, this assigns a kind of estimate based on the percentage of the total. There are certain times that you want to develop your budget, and the funder may even tell you that you can. The funder will have told you possibly the percentage for personnel is 70. The cap for personnel is 70%. So you are looking at 70% for personnel. Then you're talking of travel. Maybe travel is just 10%, and just like that. So you can easily apportion. And of course, when you are running out of time, you can always apportion percentage to your budget. So most organizations have established budget baseline. Sorry, I'll be talking more from African experience because I will not be discussing what we've not experienced in Africa. So like in College of Medicine, we have a way of doing our own budget. That is, we have a budget we have the basis of estimate, which is the basis that we have. For example, we have for salary for every researcher in the college, there is a cap for each level, and we have it across different cadre. So in different institutions also, I know institutions always have different ones. So why am I bothering you with all this information? So that takes me to the importance of having the knowledge of budget. I know there are some people on this platform could be project managers, some people could be field staff, and at the same time we have professors and doctors that we want to develop budget or asking somebody to develop budget for them. But at the same time, you still have to be aware of what is in that budget. So budget is actually the aggregate of all the estimates throughout the project period. And for example, if someone or somebody attending this is a project manager who has not been employed before the grant was won. Now the grant has been won, and of course, he needs to manage the grant that he was not actually there when the budget was developed, but he needs to work with the budget. So in that situation, he needs to understand what budget is so that he would be able to work accurately with the budget that has been handed over to him. Now, for example, now we need to know if there is budget padding. because there are some people that do bad budget padding, which is not healthy for clinical trial or for any project. Then we need to know if there is contingency, that is just an extra cost of time, which can later be redistributed, along the line. And of course, we have the management reserve, which is actually not specific to a work package, but for the entire project. And of course, the management does that a lot. Also, it could come in form of credit line, it could come in form of support at the end of the day, so that the clinical trial goes without issues. And of course, to conduct budget performance, you need to understand budget so as to know the budget performance and keep record of the differences, because there's every tendency that there will be differences, maybe a loss or a gain. We need to understand, and we need to understand where it's coming from. And of course, we need to know, this is a note, that a comprehensive and accurate budget is crucial to the success of the project. That is, it must be, at least to a good extent, it must be accurate. So the detailed cost components that I put here, just looking at different categories that we need to consider while developing budget. We have the personnel, we have the operations, and we have examples here, and we have data systems. You need to set up the system, the server, hosting, security you need to maintain, and of course, there could be equipment. Most of the time, even for clinical trial, taking samples, you need to have a place to store the samples. And of course, there will be supplies, travels, the institutional charges. There are so many people. I mean, some people, when they are developing budget, they forget about institutional charges. Like the College of Medicine, once you have your once your money comes in, part of what that will be deducted is institutional charges. And if it's not there at the time you are developing your budget, then it might impact the project itself. So one has to be very careful when developing budget. Then the ethics, the ethical approval and all that, and also training. So that has to do with the pre-award. Now the post-award, the grant has been awarded now. So what are other things that should be done? There will be invoicing, there will be other things that accounts, the grant accounts will be doing. And the very first thing that happens most of the time in the College of Medicine is for us to have a letter. And the letter will state everything that is going to happen with the project. And of course, with the clinical trial, and of course, the budget, the MOU, and of course, the agreement will also be sent to the financial controller for opening of an account. But I want to reiterate the fact that different institutions have different rules and different guidelines, and of course, different operations. So I'll be speaking based on the experience that we've gathered in the College of Medicine, University of Ibadan. And so this is what happens most of the time. And I think we have one of the best processes. I can say that. So there are different ways in which grant cash or the fund flow into the college or into the institution. It could be through direct credit. They can credit the institution directly. And of course, it could be through invoicing, because sometimes the funder may request invoice. And this is an example of what invoice looks like. The invoice dates, these are the information that are very important. That's why I just put it here. So this is the invoice date, the number the payment to, who is receiving, the name of the institution, the project title, and of course the deliverables, very important, the milestones, then the account details, then there should be signature. This is another sample. Okay, so acknowledgement and receipts of grant inflow. Request for access to operate the Grant Master. In the College of Medicine, there is a platform that is being used for grants, which is the Grant Master. So the Grant Master platform, and it's cut across it's available to all the principal investigators. Once the grant is won, or once you want to do your clinical trial, the basic thing is for you to write to the financial controller. Once that is received, then the process of Grant Master starts. The advantage of this Grant Master is that it can be operated from anywhere, even if the principal investigator is not within the country. And certain funds are needed for the clinical trial or for the project itself. The principal investigator can make requests and it will be granted, and so that the work will not stop. So that is the major advantage that we have there. And the principal investigator doesn't need to get to finance to know what is happening with the grant. Can sit in your office and everything is done. The system allows just 2 persons. So these are our processes in the college. And all request payments must be initiated on the Grant Master, as I've said earlier. So the one I discussed earlier, which is a credit line, so it's a way of supporting researchers so that the work will not stop. Sometimes when the funds is yet to be converted to maybe Naira, maybe the money will be spent in Naira, and the money has come in maybe in dollars or in pounds or in euro. So the process of converting the money to Naira before it can be spent, especially on the field. So the institution comes in that line and make sure that there's available funds so that the clinical trial can continue, so that there won't be disruptions. And we know what happens when clinical trial is supposed to be done, or any project at all, and there's shortage of funds. It's always not the best. So the institution comes in that area. And of course, for procurement, also there are different ways in which we do it. There are different ways in which we release funds. We do direct payments. This is usually through, that's for majorly for like salary, like utility allowances, like honorarium, like telephone claims, and different other payments like that. So different institutions have different ways of making such payments also. And of course, we have cash advance. This is for the payment of the expenditure, that are not fixed in nature. For example, now in clinical trial, there are so many supplies that will be needed. So in that situation, you can get a cash advance, and in the process, you get the cash advance and make sure you use it for the consumables, the sundry expenses and all that. And sometimes when you want to have conference, when you want to have training, be very short, so just for you to make sure that you plan ahead. So in the process of planning, you request for cash advance and it will be granted in the college. So different institutions have different ways of doing it, but I'm talking from the perspective of which I have experience. So the cash advance continues. Then for the cash advance also, there's a way we do the retirement, that is all the receipts, because you have taken the money in advance, and at the same time, you need to return the receipts, which must be cited by the auditors, so that we know it's not only done by the principal investigator or the principal investigators or the project manager. So the auditors are also involved in finance. Then there will be sanctions also if the principal investigator or the project manager is not meeting up as expected. It will be deducted from the salary of the principal investigator. So we have other payment options like local purchase order. I know this one cut across almost all institutions, especially in Nigeria. That's the local purchase order. So we use this one for majorly for purchase. And we use it. There are so many contractors that are used to this. So we get different quotations and we make the payment. And of course, it continues to because it has its own downside and everything that must be done. We have the procedures also to be followed. And of course, we have another one, which is impressed. There's a way we do impressed. And for clinical trial, this is also very important for them because as they are on the field, and at the same time, there will still be some people in the office too that will need to make few payments, for example, just like petty spending and all that. So this is also very useful for them. And there's a way we do the retirement also. There is a form that will be given and it will be filled and returned. And of course, the auditors will also inspect and make sure that the money is spent as expected. And of course, we have payroll. So we have the process for payroll also. So it's a way of making the payments, and the principal investigator is going to decide if the staff, especially the field staff and people working directly on the grant, if their money will be paid on monthly basis or the money will be paid as a payroll. That is, you have your name there. You will have the principal investigator will have written to the finance department that these people should be paid for the next 1 year, and another PI will say, no, I want them to be paid on monthly basis so that they raise the voucher on monthly basis. So depending on the principal investigator for that, and of course, this goes through different levels of approval. The financial controller will approve, and the provost will also approve, and the principal investigator will also initiate, and we have different levels like that. And from the comfort of your office as a principal investigator, you can view everything, including your balances and everything. So, and of course, we have the closeout. This is the end of the project. And of course, budget is still very important here, because by the time you are doing the closeout, you are looking at the beginning, you are looking at what has been spent, and at the same time, you are looking at what is left, what are the differences, the variations, what has been responsible for the variation. So, at this stage, we are looking at the scientific, administrative, and financial reports. At that time, they are all presented, and this is often the collation of all the progress reports. That is the one that has been, for example, now if the clinical trial is for 3 years or for 5 years, at least every year report will have been given. So by the time you are doing the closeout, around the 5th year, or if it's the 3rd year, then it will be the collation of the previous ones that we've been submitting. Also, to check the performance of the grant at that time. Then finally, the closeout is done and the meeting is held. So what are the areas where we can also save cost in clinical trial? Especially by the time we are developing the budget, it's always better we develop a good budget, and at the same time, we look at areas where we can also cut costs. Instead of using these our normal paper CRF, we can make use of electronic, so we can budget for that. The centralized data collection, depending on the way the data is to be collected. And we can also use co-funding, can always, because I remember there was a training we went for, and when we returned, it's one of my colleagues that actually did co-funding. We never knew it would work very well in Africa, but at least people are using it now and we are getting results. So co-funding too can also be used to support whatever we have. And of course, in-kind contributions, that is, you can meet researchers, friends, then institutions also can do kind of in-kind contribution. And even there are some funders that always request for in-kind. They just want to know what is the institution bringing on the table also. So, and public-private partnership, this enhances sustainability. That is, the continuity will always be there. So in conclusion, understanding the financial operation of your institution, which is often guided by regulations, is very important. By the time you are developing budget, it is very, very important for us to understand the financial operations of the institution. And at the same time, the guidelines of the funder, because most of the time, the funder will have guidelines, and it will have been written in the agreement, it will have been written in the MOU, Memorandum of Understanding. So we need to read and read and read again and make sure we understand it before going into budget development. Read and understand funders' guidelines. If it's not clear enough, ask direct questions. They are always ready to respond. And that is a fact. They are always ready because what they want is result. They want the best out of the clinical trial, the grant they are giving out. So they are always ready to respond to questions. So anytime we develop a budget and we have issues or it's not clear enough, the best thing is for us to call them directly or send an email. Can you clarify this area? There was a particular time I did a budget, and by the time I finished the budget, and I discovered that the personnel alone was going to over 70%. Then I needed to ask questions based on all the required activities. I've developed this budget and this is what I'm getting. So eventually the funder responded and said, well, what they're actually looking at is the cap for the project for personnel on that project is about 75%. So if I'm getting above 70%, then it's still fine. So it's because I asked questions. If I didn't ask questions, I wouldn't have known that I was actually on the right path. So the best thing is for us to read and at the same time ask further questions if required. Each organization has a way of budgeting. You may check previous budgets, that is the history, and at the same time, based on the experience also. And of course, there are some institutions that also have basis of estimates and all that, just like the one I said earlier in the College of Medicine that we have salary base. So we can also explore that budget baseline and budget annual of the organization. It's better we use it as basis of estimate. For example, now if somebody is just coming to the college for the first time and is preparing budget, if he doesn't ask questions about if we have basis of estimate in terms of salary of the principal investigators, the person will not be able to do the right budget because we have, and if he's not aware of that, he will have used another estimate in order to get the estimation of the salary of the principal investigator, and which will not be the right one. Whereas it might be right in other institutions because he might be looking at other institutions and not the College of Medicine. So it's always better we look at the previous one that has been done, then we benchmark with what the current reality, and we will be able to do a good budget with that. So to cap it all, We need to understand the operations of the institution. We need to understand the founders' guidelines, and at the same time, the organization, the way things are being done in the organization. Thank you for listening.
And thank you very much again, Mr. Sickle from UCH. Can never hear enough about money. Thank you for that. Now we have a third presenter. But before we do that, I will just, I looked at one of the recurring comments or questions in the chat room, and it's about access to the recordings. Yes, you can get to the recordings on the SESTA website, but admin has also been kind to drop the link into the chat room. So please just scroll up and then you will see the link that takes you to the recordings of the previous weeks. And this week's ones also will be on the website subsequent to this. So we have heard from Dr. Popola, quality assurance and quality control. We've heard from Mr. Somi Osi-Kolu on budgeting. We have a third presenter, and I'm going to ask Kathy to please do the honors again. Thank you.
Thank you. So it's my pleasure to introduce you to Ms. Jo McBride, who will be speaking on supply chain and SOPs. Ms. McBride is a freelance lab advisor and was previously a gene chip microarray manager at CPGR. She is an experienced scientist with more than 20 years of experience in managing microarray projects and providing training in molecular applications. During this time, she has worked in GLP and accredited facilities. She is excited about the transfer of knowledge and skills and has done so over the years in different capacities. So thank you very much, Ms. McBride, for speaking today.
Hi there. First of all, can you all hear me?
Yes, we can.
Hi there. Thank you for inviting me. I'd like to, thank you for the introduction. What I'd like to do is I need to share my screen so that I can share my presentation or show my presentation. I just need to see.
Please go ahead and share, I think.
Okay.
Right.
Sorry, I'm just trying to see where I need to share. Okay. Sorry, can somebody just advise me how to share, where to click on share on the screen?
So, Joe, if you look at the bottom,
you will just drag the screen.
Yep. Carry on. So it's
So the bottom,
okay.
The bottom, at the bottom, there's a share button.
Okay, let me just.
There's a board.
Okay.
So if you go to that green box and click on it, the arrow.
Oh, I see. I see it. I see it.
Yeah.
I see it. Thank you. Right. And I just want to do that. Oops, sorry, that's not that one. And it's Okay. Can everybody see my screen?
Yes.
Yes, we
Okay,
can now.
right. Okay, so tonight, in the session, I'm going to cover. I've been asked to cover the significance of the research supply chain, and then also SOPs. And you can see how SOPs are really integrated into just about every aspect of the laboratory processes that take place. Okay, so beginning with the with supply chain management, there is a sequence. This really means that there's a sequence of processes that enables the movement of goods from the supplier. So that would be, sorry, not wrong one, from the supplier to the lab, and within that, you need to understand and plan for things like disruptions in this framework, any challenges, and how this would actually impact the lab workflow, and then also what you would need to in order to have a successful to ensure that you're in control of all of your supplies. There needs to be the effective management of this supply chain. So when we look at the processes that enables the movement from the goods to the supplier, to the lab, we're looking at the raw materials, who's going to be providing them, the manufacturers, and the distributors. So when we look at the raw materials, these can comprise the general consumables, for example, your disposable items like syringes and needles, pipette tips, swabs, etc. And then there are the reusable or the durable consumables, which are used repeatedly, like measuring cylinders, pipettes, beakers, and so on. And then finally, there are also the chemicals that are used in all of your analysis, your reagents, your calibrators, and your controls. And then we have to look at the manufacturers and the distributors. We have to see if they, when you're trying to source them, you have to look at there's quite a bit of homework sometimes you have to do. Sometimes there's not very much homework because they come recommended, but you have to look at reliability and pricing, or whether the delivery of the goods meet the requirements of how they are being when they are being delivered to you. Do they meet are they delivered at the right temperature? Are they delivered safely? Are people actually taking care of what you have ordered? Because this costs a lot of money. What happens, for example, if you have to return anything or if there's a mistake? So you have to look, and do they? So these are the sort of things that you need to see in a manufacturer and distributor, and often it's not you don't. Always, especially in Africa, you're not always buying directly from the manufacturers. You're buying from the distributor. And if you don't get good service from the distributor, you shouldn't be afraid to contact the manufacturer and saying, hey, guys, your representative here in Nigeria or Ghana or wherever, they're not playing the game. The goods are not being delivered in a safe manner. The conditions are not good, and they're letting us down. So never be afraid to do that. It actually, because it makes them pull up their socks. So when we're looking at the procurement of your supplies for the lab, we need to see that there are efficient procurement practices in place. needed for your supplies and your equipment. And for these, you actually need SOPs, and I will go into the SOP structure later. But it's so that you have a process to follow. If if you want, when you're buying something, where do you go? Do you have a list of reliable suppliers that you always use? Who can you use as backup? And one other thing to also bear in mind is that very often people will, some distributors or manufacturers will promise you the earth, especially when it comes to high-end equipment. Just be careful, because they might offer you these things and it all looks a little bit too good to be true, and they look reliable. The one thing to remember is to ask, if there's a problem with this machine, are you going to come out and maintain it? Because that tends to be the downfall sometimes, that labs sit with white elephants because they are prepared to sell you something, a high-end piece of equipment, but they're not prepared to come back to service that piece of equipment. So that's something to bear in mind. You need to have effective stock management in order to maintain optimal stock levels, so that when you are, if you're going to have, if there's a big holiday coming up, for example, or when we had COVID, for example, that couldn't be predicted, but it's actually knowing that you're going to be able to carry out as much work as possible, that you have enough stock in place, and to build up those relationships with other people as well, so that if you run out of something, is there someone else you can contact and say, could I borrow something, and I need this very urgently. But it's, so effective stock management in order to maintain optimal stock levels actually means that you have to do things like your stock counts, and also to be able to project what you might be using in the months ahead, or if there's going to be some something unexpected happens, or especially, for specific projects. If you know what you're going to be using, then plan in advance how much you're going to be buying, and how much to actually, the minimal amount that you should always have in order to carry on before your next order comes in. Think about your logistics in order to minimize your transport costs and disruption. So if you are able to bulk buy, whether that is, you share with another center, it often makes sense, and it takes into account the costs, or minimizes your transport costs. If you are able to bulk buy, that is particularly appropriate, obviously, for consumables that are not things like needles and syringes and so on. It's a little bit trickier when it comes to things like reagents, because you have to think about the expiry dates, for example. Build a strong relationship with your suppliers for a consistent service, for really good quality control. Look at their quality control measures. How do they meet all the requirements in order to deliver something that is very sensitive or very expensive to your lab, and they can ensure that it's going to arrive there safely and at the right temperature. Of course, what you also have to consider is the proper waste management and disposal of expired items. If you are an accredited lab, not just that, but if you're practicing GLP as well, it's essential to to understand and to implement a very good waste management system, and also to ensure that you are not working with expired reagents, because these things like this, expired reagents can compromise your results. Then there is the use of it would be fantastic if you have an integrated information system like a LIMS system, where you can have the seamless management of reagents and consumables. And having something like that in place, it can tell you how your stock is moving, and then it also gives you the ability to forecast usage for any work that has to be done down the line. So, and with that, I want to go now. When we were, when I mentioned when I was going through the stock control, the one thing, all of the things that I mentioned, actually would benefit. They always benefit from having an SOP in place, and the reason. Because then everybody in the workplace understands what has to happen, what are the things you have to check up on, and the flow of how things are done. So why are they necessary? Well, firstly, an SOP, or a standard operating procedure, is the documentation of how a process is carried out. And these SOPs should provide a step-by-step list of procedures that anyone can carry out following proper training. So having SOPs in place ensures that everyone in the workplace understands the instructions to a process, and therefore prevents or reduces the introduction of any variables or possible errors. Why are they beneficial? Because they allow replication across your organization. Where followed correctly, there should be reproducibility. Where the same procedures are carried out by a different lab, by different people in the lab, or across different sites correctly, there should be reproducibility of results. And this allows for identifying any variation of results that might be observed. So having an SOP in place for a particular procedure allows an employee to understand exactly how to perform a specific task without having to ask too many questions, and there's also a clear understanding of what is expected, which in turn helps them to monitor their performance and therefore also achieve the correct results, and it also teaches them how to troubleshoot. So also the one thing that we find with having SOPs in place is that when a key member of staff is unavailable, for the work can still continue. And that's important, that more than one person is trained to carry out an SOP, so that someone else will always be available to take over an urgent task. And when I was involved with the MADCAP project, and that's one of the things that we had to do, I had to ensure that everyone in the lab was able to take over any task in the sample processing, and that actually built in redundancy, and it worked really well, because there were times when, for example, if somebody was ill, or there was delay in traffic or something like that, someone could always take over where the previous person had left off. So when do you need to create SOPs? You would need to create and implement SOPs when you have a set of processes or protocols that will be used repeatedly in the workplace. Because by having these SOPs in place, it would allow employees and lab staff or students or anyone who has to carry out a process to work to a standardized protocol. Decide what SOPs will be required. And this you can do by mapping it out, and you can see what needs to be covered. And this can even take the format of for example, a process map. So SOP development isn't a task to be carried out just by one person. In your lab or organization, everyone who plays a part in the processes or the applications taking place in your lab also has a part to play in SOP development. And this includes reviewing each other's SOPs for accuracy and being able to understand the SOP. Just remember, SOPs need to be understood by all who will be carrying out the processes in the lab. So this is just an example of the of how we used to go about doing mapping a workflow. So this workflow is really applicable to the journey of samples from the time that they are collected through all the different applications that they have to go through. And by doing something like this, you can then see how you can develop your SOP. And, maybe you would have to have, say, for example, separate SOPs for maybe two of the collection steps, for example, or you can just amalgamate all of them and have them in a single SOP. But at least you are able to identify each step along the way so that nothing is left out. So by creating the workflow, and this can always be updated, it will allow you to identify what SOPs you will need to have in place. And then you can also work out from there, you can see who can be responsible for the development of the various SOPs. Make sure, so if you're having, for example, so just looking at this process map, we can see that upon samples arriving at a lab, how they will be logged so that you have a record of having received them. The details should be captured electronically, as well as in hard copy, and I'm sure you are aware of that anyway, but it's just a kind of reinforcement, so you can always cross-check. And it's also when, as the sample goes along, along the way, that chain of custody, everybody understands what has been done previously. So when samples are handled on receipt, you have to describe the different sample types that might have to be handled, for example, or how they must be handled in order to, for example, prevent hemolysis. Are samples allocated a barcode or a lab ID? Who in the organization will be processing those samples? Do they need to be notified of the arrival of these samples? And if so, then you have to confirm that that person has been informed that samples have been received. Then again, will the samples be transferred to different storage tubes or containers prior to storage? How and where will the samples be stored? You need to identify the fridges, freezers, shelves, cupboards, and for sample processing, identify the applications to be used, identify what constitutes a good or bad sample result, and by using a workflow like that, you can develop this as part of your SOP, because it helps you to define within the workflow the number of SOPs that will be needed. It will also help to define all the steps, defines the timeline of a workflow, and even to identify areas, equipment, etc., where these processes have to be carried out. So it's an important note for labs working within or towards certification that SOPs must be numbered, including a version number. They must be dated. They must be reviewed and signed by the person in your organization who is authorized to do so. If you are a certified lab, you will probably know how important it is to ensure that you are working within an SOP that you're working with an SOP that falls within the date because you can, even though there may not have been any changes to it, you still have to show that it has been reviewed, and so you provide a new date and then a date when it will next be reviewed. So there are other ways that you can also use workflows for mapping out processes, and I've just filled in two of these little circles, and sometimes you can, we used to use them quite a lot because it used to help us to. We actually used to put in some, where for example, what equipment needed to be used, because when certain equipment is in high demand in a lab, you need to ensure that you can actually, sort of book the equipment to make sure that everything is available on the day that you need to use it. It may not always apply in analytical labs in that, equipment will always be available, but certainly in some of the research labs, that for us was a requirement. So just in summary, what are the importance of SOPs? They help to standardize your work processes, enables the reproducibility with respect to experimental processes. You can also monitor how people are performing, how your workers are performing, the method validation, and helps to maintain a high quality of work standards in your lab or institution. But above all, taking all of that in mind, training is the most important step when implementing an SOP. And people are more likely to follow procedure when they fully understand its importance. Thank you for listening.
And thank you very much, Joe, for that presentation.
You're welcome.
Yes, thank you. And spoke some to what Dr. Popola mentioned also at the beginning of the presentation. So we have a few minutes for questions before I turn it over to the director of CESTA, Professor Nodu. So if you have questions, please signify. The only other comment I can see in the chat room is by somebody who wanted an introduction of the second speaker. I would just say he's Mr. Somi Sickle, and he's of UCH Ibadan. That's the brief on him for now. So, any other questions concerning any of the three presentations? Please feel free to signify, and you'll be unmuted. Okay. This says to me that we have understood everything.
Okay. If anyone has any questions or would like to contact me independently, I'm quite happy to answer questions. Not a problem.
Okay, very good. Some other comments? Yes, practical presentation, especially highlighting things that are easily overlooked. It's a comment to the presentation. Thank you.
Okay.
I will hand over to Professor.
Okay. Yeah. Thank you, everyone. Thank you, Tayo, for the excellent moderation. Thank you, Katie. I really want, on behalf of the House, I want to express our sincere appreciation to speakers this evening, ranging from public community medicine, family health to the last presentation that we had just now. So I want to thank Joe for the talk on research supply chain standard operating procedures. If you people notice, we have spoken about SOPs twice this evening, and this is because of its importance in regulatory, in clinical trials, and it's really something that the regulatory agencies look out for when they come to site. So we've considered quality assurance, quality control, and then laboratory procedures and sample logistics, quality management. And then, very importantly, we've talked about budgeting for clinical trials. Mr. Sonny Oshinkolu, my finance officer, wanted to be introduced to you. So I hope that we can get if maybe you can put your contact in the chat box and he can pick it up and speak to you. His name is Mr. Aminu Adebiyi. So these are very important topics that we have listened to this evening. Remember, what we want to do is to make sure that all the SparkNet sites and more besides are ready for clinical trials. There are a number of them that are already conducting clinical trials, but we want everywhere that we have this registry of over 10,000 patients, that the centers will be primed to be able to participate in clinical trials in the service of our patient population. So I want to thank everyone. We have learned a lot as usual. I want to thank all the presenters on behalf of all of us, and I want to thank everyone for listening. Remember that this training is going to come to a conclusion on the 27th of November, and then we are going to have a post-test. For the certificate is 100% attendance that is required. So please check in the chat to ensure that you each time you log in, for this training, you record your attendance. So I want to thank all of you. And there is, if you look on the SparkNet site platform, there is a questionnaire that we want to use to document the the capacity, right, of a clinical trial at each site. So please try to fill in the questionnaire. It has a very short turnaround time because we also want to write a paper on the clinical trial capacity at the SparkNet site. So please let us try and pay attention to that and turn them in so that we can analyze, and on the last day we have a presentation of how the sites are doing. And this can also be an advocacy tool with government to equip our sites better, for clinical trials. Thank you very much. Thank you and good night.
Good night.
Good evening.
Good night.
Thank you.
Good evening. Thank you, everybody.
Good night.
Good night.
Well, please, I have a little question, please.
Okay.
Please, about the question that you say we can get it on the SparkNet. Is it on the app or from the site, ma?
The the SparkNet, we have a platform where the SparkNet PIs interact. So if you're from one of the SparkNet sites, your PI will have that questionnaire. It's already there. So please go through your PI, yes, and then. But if you're not from a SparkNet site,
Please, is Dr. Kenjo aware of that?
of course he is part of us. Yes, yes, he is.
Okay,
Yeah.
I'll ask him.
So please,
Thank you,
yes,
ma.
it's there already. It's there. It was
I'm speaking
posted.
on behalf of FTH Branding KB.
Yes, of course, yes. Thank you. So you will meet him, and
Thank
then
you,
you
ma.
probably read it quickly. Yeah, thank you very much.
Sorry,
Thank you.
Dr.
All
Kanjwa
right,
is
ma. Thank
in
you.
attendance. Dr. Kanjwa is in attendance. I can hear you. Hello? Hello, ma. Hello, ma.
Yes.
Yes. Yes, I'm seeing.
Hello,
I
ma.
think I have question here. Yes.
Okay. Thank you.
Hello, my hand is up, ma.
Yeah.
Yes. Go ahead.
Please,
Eunice.
ma, last week I was on the lecture, but network logged me out. I couldn't even register my attendance. This one you are saying 100%, I've never missed one day. But last week, I couldn't enter my attendance. My attendance, I couldn't enter. And even if you see, you will still see message I sent. I don't know whether they delivered.
Zoom has a way of documenting attendance, right?
Yeah.
You can say you were there for 5 minutes, you were there for 15 minutes. So we check all of those things, okay?
Please do, ma. Please do, ma. Because network was so bad last week. I couldn't complete and I couldn't register my
Hello.
attendance.
Okay.
Thank you, ma.
Yeah.
You have a nice work, ma.
Okay, you're welcome.
Wanda mota ta kuce ka an samu matsala.
The Director General, Media Communications to
Who is firing? Anyway, we have finished. Good night.
Huh? Yeah.